because of COVID-19, it's not possible to do that. So instead, we're going to be recording the meeting, and it'll also be accessible on the CCG website. So I'm assuming by people's continued participation that they're happy with that. If I can make some introductions and some apologies for absence. We've got let's have a look. Just to allow for the smooth running of the meeting, if I can ask people to put the mobile phones on silent, please. If you've got the Tees Valley background, if you can display it. If you can put yourselves on mute, unless you're actually speaking, to just reduce the background noise, that would be smashing. And then if you can raise your hand if you wish to participate in the discussion, and I'll bring you into chair at the appropriate point. It'd be good if you can use the hand feature as well, the raise hand feature. I've got 4 people on my screen at any one time, so I tend to flick across it. But if I miss anybody, please just shout up. And then if you need to leave your seat during the meeting, if you can just put your video off, that would be smashing. And if I experience any technical issues, which I don't think I will, then I'll pass over to Michelle Thompson, who's the vice chair. I understand that we've got one gentleman with us who's a member of the public. That's Brian. Hi, Brian. Welcome. Have you got any particular interest, Brian, or are you?
Just mental health.
Oh, lovely. Well, thank you for joining us, Brian. I hope you enjoy it.
Okay, then. Thank you.
Okay, thank you.
I'll go back on mute.
I'll go around and get people to introduce themselves. So I'll just go in the order of my screen. So I'm Caroline Gitcham, and I'm the chair of the Primary Care Committee. David, I've got you next.
I'm David Emerson, Secondary Care Doctor on the governing body of the CCG.
Rachel.
Hello, Primary Care Commissioning Officer. I've just started with the CCG.
Oh, lovely. Welcome, Rachel. Hannah?
Hi, I'm Hannah Heron. I'm Finance Manager. I work for NHS England, but I look after the delegated primary care for the CCG.
Thank you, Hannah. Lisa?
Hi, Brian. Project lead for Healthwatch South Tees. I think we're meeting tomorrow, and look forward to exploring more links with you. But obviously, we are the critical friend, shall we say, for patient and public voice.
Thank you, Lisa. Nick Timlin.
Hi, I'm Nick Timlin. I'm a GP in Hartlepool and also executive GP for the CCG.
Thanks, Nick.
Can you see me? Because I don't even know if me.
No, there's just
it's not on.
silhouette.
I can't tell. So I'm just a name or something.
And then, I've got Michelle.
Hi, I'm the Tees Valley CCG lay member for patient and public involvement, and I'm also the vice chair for this meeting.
Sue.
I'm Sue Greaves. I'm the head of commissioning and strategy for primary care for NHS Tees Valley.
Lovely, thanks, Sue. David.
Hi, I'm Dave Gallagher. I'm the Chief Officer for the CCG.
Lovely. And then we've got Lynn.
Hi, Lynn Watt. I'm Deputy Chief Finance Officer for the CCG, and I'm deputising on behalf of Mark Pickering today.
Smashing, thank you, Lynn. The other Lynn?
Hi, I'm Lynn Pearson. I'm Corporate Secretary, and I'll be taking the notes today.
Lovely. And Karen?
Hello, I'm Karen Hawkins. I'm the Director of Commissioning for Primary Care for the CCG.
And I think that's everybody. Is that right? Yeah. I think I've flicked across all my screens. Lovely. Right. That's great. Then. Well, we'll make a start. Oh,
Caroline, Janice has joined.
Oh, sorry, Janice. We're just doing introductions for Brian.
Sorry for joining a little bit late. Janice Foster, Chief Exec, Cleveland LMC.
Lovely. Thank you. Right. Well, we'll make a start, folks. So let's have a look. Obviously, there's an opportunity, Brian, for you to raise any questions that you've got at the end of the meeting, if you'd like to. And then we've got, let's have a look. We've got apologies from Jean Golightly, Mark Pickering, but Lynn Walton's attending in his place. Ali Tamasibi, Janet Walker, Jenny Long, but we've got Kelly Wilson. I didn't see Kelly attending in place of Jenny. She might join us later. And then Esther Mirakwai. So they're the apologies, but the meeting is quorate, so we can continue.
Caroline, sorry,
yeah.
can I just jump in? There's also Robert Upshall from Health Watch Darlington. He put his apologies in as well.
All right, lovely. Thank you very much. Thank you. So if we can go on to, is there a notification of any other items of business that need addressing at this meeting? I don't think I've been notified of any. No, okay. If we can go on to declarations of interest, if I can remind people that if they've got any declarations of interest that don't appear on the register, if they can raise those now. I haven't been notified of any. No, okay, that's smashing. And then if we can go to the minutes of the meeting held on Wednesday, December the 16th, on page 52. So can people confirm that we're present, that they are a true record of the meeting? Yeah, lots of nodding heads. Yeah, lovely. Okay. And then if we can go to the matters arising on the action log, there was 2 matters arising. There was one, David, that I think you'd raised, and the proposal is that comes back in August. Are you okay with that?
Yes, I'm fine with that, but maybe if it were to be adjourned again, perhaps just a bit more debate, but I think 6 months is reasonable, yes.
Okay, that's lovely. Thank you, David, for that. So if we can go into the items for decision then, we're on to page 54, and that's the draft annual cycle of business for 21-22 and proposed meeting dates. So obviously this is a standard item that we have on the agenda. Is anybody going to take us through that one?
Sorry, Caroline, I couldn't get myself off mute then.
No, it's okay.
So in relation to this is a presentation of the annual cycle of business that comes to committee at the start of every year. So it really is for committee to have reviewed and to agree that it incorporates the inclusion of the primary care networks and also the primary care risk overview, which is included in the annual cycle of business. So it's just to aid the committee in terms of planning for future dates and to ensure that all committee members are cited on the areas that will be discussed through the committee and the dates that the committees will be held. So it's for decision and agreement today.
Great. Are people happy to agree that we've got all of the items covered that we need to discuss and the dates?
Yes.
Yep. Okay. Yep. That's smashing. So if I can take us on to the next item then, and that's on page 55, and that's the terms of reference. Kate, are you able to take us through that?
Caroline, Kate's not attending the meeting today, so I've agreed to pick this up on her behalf.
All right, lovely, thank you.
So this is the Primary Care Commission Committee terms of reference. It is for the committee to make a decision in terms of confirmation. It's for confirmation of the terms of reference and the recommendations to committee. It's for it's an annual review of our terms of reference to ensure that they're fit for purpose. And they were also, just to cite the committee, as you'll have read through the documentation, that the terms of reference, when we became a new Tees Valley CCG, were reviewed robustly at that time to ensure that we were able to comply with our requirements under NHS England's delegation were approved at that time in February 2020. So this is the annual review to ensure that the committee is cited again on the terms of reference, the areas that are set out, and also to remind the committee that any changes to the terms of reference would need to be agreed and approved through NHS England. So really it was to cite the committee again and to ensure that the committee were clear that they have been reviewed, they are expected to be fit for purpose, but to gain committee view and agreement that these are our terms of reference as we move forward in the next year.
That's great, thank you, Karen. I think it's always useful to remind ourselves of those on an annual basis. David, I can see that you've got your hand up.
Yes, just a question. As obviously after over the last year, COVID has had an enormous effect on patients, staff, and really much of the business covered by this committee. I just wondered if we needed to have any addendum just to confirm that any specific COVID-related items would be covered by the committee, not necessarily a formal change of the reference, but I just wondered if some addendum might be required because of the extraordinary circumstances over the last year.
Yeah, certainly in response to that, David, the terms of reference obviously set out the annual cycle of, correlate with the annual cycle of business. Even though there's been the pandemic throughout this year, we've continued to appraise the committee through the annual cycle of business, and any delegated decisions have been fed back to the committee. We provide a general overview in response to COVID in terms of the primary care response to COVID as part of our agenda items. So there wouldn't necessarily need to be a reference within the terms of reference to the pandemic, because obviously that's covered under force majeure in how we work. But certainly we covered that already on the agenda if that would satisfy the committee.
Is that okay, David? Yeah.
Yes, I think so. It's just in the terms of reference. There isn't a lot about emergency preparedness and resilience as such, but obviously this has been very much in the forefront. But as long as we feel it is adequate and meets scrutiny purposes, I'm happy.
Okay, that's lovely. Thank you. So we're happy to approve the annual review of the term of reference. Yep. Okay, that's smashing. If we can move on to the next item, then that's on page 56, and that's Sue is going to take us through the COVID-19 response.
Yeah, thanks. Yeah, so this is the can everyone hear me? Because I've got a message to say that my sound on my computer's not very good. Can you hear me?
It's better when you're closer, yes.
Yeah.
Yeah.
You don't need to see, you don't want to see me that close up. Yeah, so this is the regular COVID update to committee in terms of the primary care response to the pandemic. So in terms of branch closures, we have two branches and a practice that are closed at the minute because they have been designated as COVID vaccination sites. So that's Riverside Medical Practice in Stockton, the Park and Thorntree branch at North Ormsby, and the Linthorpe branch at North Ormsby. In addition, Hartfields remains closed, the Hartfields branch site, as does the Zetland branch site, and that really is due to environmental issues in terms of the size of the premises and being unable to make the premises COVID secure. So we're asking committee today to ratify the continued closures of the two branch sites to the end of March, and also to ratify the 3 sites that have been designated as the local vaccination sites. In terms of oximetry at home, as you won't be surprised to hear that the activity in the oximetry at home service significantly increased during the second wave, in line with hospital admissions and hot clinic activity as well. And at some points, probably about 3 or 4 weeks ago, on a number of days, the number of patients who were being monitored actually exceeded the capacity in the clinic. So a lot of activity going on. Just to give you a feel for the number of patients, the service originally started, you remember it was called the COVID virtual ward when we first started the pilot. That commenced in July, the end of July, and 814 patients since the end of July have been referred into the service, of which 616 have met the criterion and agreed to be monitored. So a significant number of patients have successfully gone through that. We are expecting nationally that the criteria for referral will be increased. At the minute, it's patients aged 60 and above, and we are expecting that will be reduced to 50 and above. So we're just doing a piece of work at the minute, assessing what the impact of that might be, not only in terms of the oximetry at home service, but also in terms of the hot clinics, because they they see that any patients that need a face-to-face consultation are referred from the oximetry at home service into the hot clinics. The impact of that might be. In terms of the hot clinics, they do continue to be repurposed, so we've got hot and cold clinics running at the moment. And similar to general practice and other areas of the system, they have experienced some significant workforce pressures in terms of staffing who have been either sick, self-isolating, quarantining, etc. And in South Tees, that has resulted in a number of the clinics having to be rescheduled. So clinics that were due to be delivered on an afternoon have had to be rescheduled into the evening. We have been looking, we've been working with the Federation and looking at areas where we can support in that in terms of mutual aid across the other federations, and working with the trust, with South Tees Trust Foundation Trust as well. Although we recognise that if the pressures do increase and continue the way they are, then we may need to review how the model is delivered. And although at the minute the similar pressures haven't been experienced in either Stockton, Hartlepool and Darlington, that's not to say that that they might not experience similar issues in the future. In terms of vaccines, that obviously continues, and just by way of an update since the paper was written, we have received deliveries of vaccines this week, enough vaccines to every PCN to ensure that patients in cohorts 1 to 4 can be completed this week. And then PCNs will be moving on to cohort 6 with which is the national directive, because patients in cohort 5 will be being picked up through the national booking system. So patients in cohort 6 are the clinically vulnerable. And then at the minute, we're also evaluating what the requirements will be for the second dose deliveries, which will commence the beginning of March. That's the update. If there's any questions, I'll try and answer.
Thank you, Sue. That was really comprehensive and really helpful. I've got a question from Michelle.
It's just a query, really. You know, the oximetry service and those that don't fit the criteria. I was just wondering if they're encouraged to monitor themselves by buying their own device. I'm just thinking through COVID and everything. Sometimes, you know, I mean, just going by personal experience, I bought one just because I was worried.
Right.
I'm just wondering if any, you know, if that is a suggestion within the system.
I mean, that probably is. I don't think they are at the minute, but obviously as the criteria expands, and you know, I think patients are generally now a lot keener to kind of monitor themselves and do things proactively rather than reactively, as is the system as well. That might be, I'll certainly feed that back in.
I'm just thinking for just that self-management, it worked really well for me when I rang 111 because I couldn't breathe during the night. And I've been looking at the oximetry, I can't even pronounce it, but anyway, that device and the thermometer and everything. I could give my obs over the telephone so that they knew whether to send an ambulance.
I know
or not.
we did discuss that, to be honest, Michelle, at the time where there were a lot of patients who didn't meet the criteria. I'm to be honest, I'm not really sure how well that has been received or taken off, but it is something that I'll take back to the board.
Okay, there's just another query as well that I've got on the vaccination programme. I'm just wondering whether in the system it's really frustrating the PCNs with the national letters that are going out, because I know that it is frustrating patients, so that they'll get a letter that comes out saying that they can go to that they have to ring 119, and then they're given a selection of places that they can go to.
Yes.
But what they're not saying on the phone call is that if they can't get to those particular places, that they will be contacted locally, or they can do it. I don't know whether it's the same across Tees Valley, but for Darlington you can do it online.
Yes.
I'm just wondering what that actually feels like within the system, because although, you know, everybody's doing an absolutely fantastic job, and I can see from a national point of view getting the letters out to as many people as possible. I can give you one example. The village that I live in, although it's in North Yorkshire, somebody was asked, rang 119 and was told that they had to go to Great Yarmouth, which is a bit silly.
Right. I mean, I know that there's some comms being developed, further comms being developed around the cohorts 5 and 6 to get to make the message to patients clear, because obviously patients who are in cohort 5 would expect that they would be the next group to be called before 6, but they're actually split in the cohorts. So the mass vaccination sites through the national booking system will be focusing on the cohort 5, which is over 65s, and with the PCNs and the local vaccination sites focusing on cohort 6, which is the clinically vulnerable. And so they're working on some comms now, I know, to try and make that message really clear. I don't know whether, Karen, were you trying to come in there?
Yeah, in terms of the comms that have gone out to patients, it has been amended, Michelle, from the first cohort. So the letters didn't originally state that patients had a choice, and that if they didn't want to, either on the letter itself, it gives the web address that they can link onto to go onto the national booking system, and it also gives them the telephone number, because not everybody's digitally enabled to be able to access the web link. And it now states in bold in the letters that this is a choice, and that if they don't wish to choose to go with a mass vaccination centre, they can wait, and their GP practice will contact them. We know that there's been issues when some individuals have been ringing 119 and they've not been advised that actually you do have a choice, and that you can wait till your GP contacts you. And some on the national booking line have also been telling them to ring their GPs, which we're trying to avoid inundating GPs and practices with calls, because they're trying to do routine activity as well as doing vaccinations, and we need to make sure that patients can still access routine care as well as the vaccinations. So our message has been, and we've been promoting that through our comms, is that there is choice. You have the choice of mass vaccination if you receive the letter, otherwise you can wait and you will be contacted by your GP. We've also escalated up through the national team, through the regional vaccination centre, that there is problems with the 119 messages, and that we need some consistency in approach, so not to cause confusion. In terms of the referral, now what normally happens is it's within 45 minutes that you're meant to, your centre, your new centres come up. So if you go online and you log on online, your nearest centre will come up. It's normally within 45 minutes, but I must say that's as the crow flies. So often it can be a lot further than is reality when you know the geography of the local area. But it will bring up everything that's available across the country for mass vaccinations. And that's the same information that the 119 service are looking at when the patient calls through. And obviously they provide them their details and their postcode, but it does bring up the list across the country that is available to them. But really the referral should be within 45 minutes travel distance, which is easy if you understand the geography and the localities, which is more difficult through a national service. But they are absolutely looking at it, and we're trying to support the messages out to the public in relation to that.
Yeah, that's really helpful, because, and I'm pleased that it's been acknowledged further up, because, you know, I can imagine how frustrating it is for GPs as well. So yeah, that's great to know. Thanks, Karen.
Smashing. I've got a few hands up on this one. I've got Janice, and then Lisa, and then David. So over to you, Janice.
Like I've jumped the gun there, because I'm sure others had the hands up before me, but I'll go anyway, because it follows on from Karen, and it was really just to say that the multiple avenues of vaccination are needed in order to get through all the cohorts and to get the volume of vaccines out. It is frustrating, and it is frustrating within the system and for patients in terms of trying to navigate all these different avenues, but everybody is working as hard as they can on the comms, and it is something that, you know, we can only do our best to address from a national perspective. I think one of the things that I wanted to raise was just around deprivation as well, and in the report it mentions about plans in place and working with local authorities on homeless, for example, travellers as groups. What we're actually finding in practice is it's areas of high deprivation who are struggling to access the vaccines, and whether it's down to traditionally what the booking systems were, so online, as Karen said, and not everybody is online enabled, or whether it is the travel to the vaccination sites. So it's really, obviously as a vaccination group, everybody is working and looking at this, but I think this is going to be a big priority for us, and a big focus to make sure that we're reaching all of these groups, because they will be missed when we're working our way through the cohorts otherwise.
Smashing. And Lisa?
Yeah, again, just on the back of that was around accessibility. We're getting a lot of intelligence, specifically from deaf communities who are really struggling to find anywhere local that has an interpreter on site to explain some of the process, some of the things that they need to look for or consider or do as a result of, etc. And I know that deaf communities in particular, when it's they're getting information that then they have to react to, is they're sending them quite far out of the area because there's an interpreter there, which not everybody can travel. So it was just to feed back some of that intelligence that's coming through for us that might need to just consider in terms of accessibility of vaccine centres.
Oh, that's really helpful to hear, Lisa. Thanks for sharing that. David, I'll let you have the final word on this one.
Yeah, thanks, Caroline. And this is a really good report, Sue. It's very, very succinct and can never do justice to the amount of work behind it, is the first thing I would say. And particularly two areas of success that we've rehearsed. The COVID virtual ward, as it was called, has particularly stood out as being an exemplar and something we need to refine as we go along, but it's had a huge impact on reducing the numbers of people going into hospital, and therefore it's really helped with the overall effort. And the vaccination programme, it's not finished yet, it's the first thing I would say, but actually to go from a standing start just before Christmas to where we are now, with all of cohorts 1 to 4 offered vaccines, and we're getting into the further cohorts, despite some of the challenges with picking this up so quickly and some of the logistical challenges, is a big testament to how everybody's pulled together, whether that's the people actually providing the vaccines, the PCNs, the CCG team, the FTs. Everybody has really worked really hard with local authority colleagues as well to get this place. So it's not over. It's probably not even half time yet. Probably the end of the first quarter, if we want to use a sporting analogy, but fantastic achievement so far. We just need to make sure as we go forward, we continue to make this bigger and better as we get into the rest of the population. But yeah, really fantastic piece of work from everybody.
Brilliant. Thanks for that, David. So if the committee are happy to, if the committee are happy to note the report and to ratify the continued closure of the branch surgeries and Riverside Medical Practice and review the dates as outlined, is that okay? Yeah, got a few nodding heads there. Yeah, that's smashing. Okay, I'll move on to the next item then. So the next items are for discussion. Yeah, so we're on to page 57 now, and it's the primary care budget, and that'll be over to you, Hannah.
Yep, thank you very much. I think I'm off mute. Yep, marvellous. This is the report for December, so month 9 of 2021. Just to go through our position at month 9, I have instantly spotted an error, and I will apologise now because my heading on the actual table says October. So I'm even just looking at anything typical. So it is actually December's. All the figures are December. So I apologise for that, and I'll wrap myself over the knuckles. So in month 9, we actually released any prior year slippages, pressures, etc. that we had seen coming through the system. So where we had put costs in for certain elements last year, which was 1920, and those haven't come about, haven't materialised, we've actually dropped those into the position. And you'll see on there, there's on the table, you've got the 1920 impact of a 758,000 benefit. So this is where we have put accruals in for areas. The big hit areas are QOF, some of the enhanced services and locum fees. So a lot of these things don't happen at the end of the year by March, so we have to put an accrual in for them. And it's usually, best guess what we think they're going to be, and then obviously they come through in the new year. So we've dropped that in. What I wanted to point out is that we actually had more than 758,000. We had just over £1 million worth of slippages, but we did have some offsetting pressures, which I mentioned on the last meeting that we had, around elements to do with premises and management fees. So obviously, at the same time as taking it into account the slippages, we've actually put in some accruals and forecasts for prior year pressures around premises. So we've been able to offset those, because there were some quite junky ones in there for the management fees for property services and CHP. So we've been able to offset those. So bottom line, we were looking at a 758 benefit. With that in mind, we've also gone through and then looked at what we've got in for this year. Still working off the back of the premises, and obviously all of the information that we've fed in over the last few months with increased rents, reviews, etc. Obviously, this has given us the opportunity to be able to, go, right, actually we do know we've got big costs coming through. What have we got coming up? What we've got rent reviews coming up, and putting something in for those. So basically, that's what we've done. So we've been able to feed into the position, those costs that we're expecting to see come through. The bottom line on there, on GP support fund, you'll see there's a 263,000 pressure. This is the funding that was given to us nationally, which was originally notified to the CCG at just being over 2 million, and then and then shortly after said, actually no, it's actually going to be 1.8, and the CCG made the decision to stick with the original figures and fund the 2 million out to the GP practices, and we would find that 263 difference from within the primary care budgets or elsewhere within the CCG. So that is showing as a pressure on there, and that has been paid out to the practices. So basically, that's leaving us with about a 200,000 pressure forecast outturn. The only other thing I think is important to mention is I've mentioned on the report under risk the potential for underperformance on PCNRs. At the time of closing month 9 and going into month 10, we were undertaking a piece of work around the forecast of where we think we are with all of the additional roles that have been recruited within the different PCNs, and where that spend was going to be. Up until month 9, we've been using a national toolkit that you put in the plans from each of the PCNs and the whole times they think they're going to recruit, and it uses a sort of a top whack estimate of what that salary is going to be, and gives you obviously a forecast outturn. So we've been using that in our positions, but now we've got into sort of month 9 coming into month 10, we're seeing the claims come through. Quite often they're sort of three months behind, so but we're seeing them come through for most of the posts that have been recruited, and what we are seeing is a gap between the actual amount being paid through those salaries and the amount the toolkit was providing. So point of doing this, we were undertaking exercise. So it was just a forewarning that I do actually think we will be seeing slippages on ours, and now we've done month 10, I do know we have got slippages on the ours line. And that will be working its way through the system. I think that's about me. Is there any questions, or does Lynn want to feed anything in on that either?
I was going to say, has anybody got any questions or any observations for Hannah? I'm just flicking through my screens.
No, nothing to add, Hannah. That's a comprehensive update on the finance position. Maybe one thing is around, we have got an early heads up, a notification that we will be working under the same financial regime for the first quarter of the financial year that we have been for the last 2 quarters of this current financial year as well. So that will make a little bit of a difference to our financial planning from a primary care committee, but we'll update that in the next committee.
No, that's brilliant. Well, thanks Hannah for that. People
No
happy
problem.
to receive the report. There's no recommendations with it. It was for discussion. Yeah. Okay, I'll move us on because we are. I'm nearly on schedule with the timings this time round. So the next one is the primary care quality and assurance update, and Karen's going to take us through that. This is on page 58.
Thanks, Caroline. So this is for members of the committee to consider the content of the report. It's in line with previous reports that have been presented to committee in accordance with the standard operating process that's previously been agreed with committee in relation to managing quality and assurance within primary care, and to ensure that we fulfil our delegated duties as set by NHS England. For committee members, you will have read through the report and you will see that we have identified no new concerns that have been escalated by CQC, and we have no practices currently with a quality improvement plan in place, although we still do have practices that have CQC requirements that are outlined in the document. Now, the report sets out the sources of the intelligence that we use to determine any actions around quality improvement plans, and also committee will be aware that we have CCG executive GP leads, some of who are on the call today, that have responsibility to ensure that our practices are sustainable, that they're providing quality care, and that they are reducing variation across practice. And that's the work that our executive GPs and with the team to identify any practices that may be outliers and that may require support in relation to any quality improvement plans. So the service in terms of the quality improvement approach is clinically led. So we provided an overview in terms of the CQC rating as we do in each month that we present the report. You'll see that there are 2 practices rated as inadequate and 1 still requiring improvement, and we continue to work with both of those practices to ensure that they're able to meet the requirements as we move forward. We've outlined within the documentation all of the intelligence that we utilise. You can't look at one piece of information in isolation of other information that may be available, so we use a range of information that is set out in part 4 of the report, which includes our CQC information, GP indicators and OPO reporting, looking at our emergency preparedness, resilience and response framework, and that may provide some assurance from the question that was asked previously in relation to how do we ensure that we're responding to changes that might happen throughout the systems through the year to ensure that primary care is still sustainable. Obviously, there's the quality and outcome framework and the population stratification, and there's other forms that we provide in terms of practice support. So we do provide support to practices by provision of a weekly primary care bulletin to make sure our practices are up to date. That's further supported by the information that the local medical committee also provides to practices to ensure they're up to date with any national or local guidance that might be presented. We also have our primary care commissioning officers that have worked continuously throughout the pandemic to stay in touch and regularly contact practices to make sure that we're building on those relationships and to ensure that we're able to provide support where that may be necessary to practices. And there's also the facilitation of training and education. However, although at the moment training and education has really, our focus has been on the pandemic and ensuring the practices are sustainable in delivering the COVID response, there has been work that's been undertaken already with practices throughout the pandemic in relation to medicines optimisation team support, and also our respiratory lead nurse has provided some virtual support for practices, particularly in relation to COPD and asthma, whilst we go through this pandemic. So the next update will be provided to committee in August, unless there's any items that do require escalation. throughout the coming months. We would obviously provide that in advance of committee. But as we stand currently, we're in a good position in terms of no new concerns. Thanks, Caroline.
Brilliant. Thank you very much, Karen. That's a really, really comprehensive report. And as you can see, there's a number of things in place to make sure that we're assured. It was good to hear the progress that's been made as well in relation to the requires improvement and inadequate. So that was reassuring to hear that. Has anybody got any questions or any observations for Karen? Michelle, I can see that you've got your hand up.
Yeah, it's just an observation. It's on page 44 at the top about the app. I really like that. I like the idea of that. The fact that you can that practices can record the pressures that the system is under, and that there's a greater awareness of the pressures as well across primary care. I just, yeah, when I read that, I thought, yes, very good. Thank you.
Janice?
Just following on from that really, and it's just to do with those pressures and the reporting of it. I know there's a lot of time and effort put into developing the framework, and it was just to see if that has actually been shared more widely, because I haven't actually seen the final framework that came out of that, and it would be really helpful for practices to be able to see in terms of their mutual support and what it is that they're reporting against versus what the returns are and what the benefits are. The other thing was really just an observation is we spend a lot of time when we look at the CQC reports of picking up where it requires improvement, and it's great to see that development work going on. But we've got two practices in the area who have outstanding ratings, and I'm not sure that we actually praise or shout about those who are doing really well as much as we should. And it was just whether there was some consideration to where somebody's got outstanding, and we parachute people in where somebody is inadequate or requires improvement, but perhaps we don't sing the praises of those who are doing as well.
Point well made, Janice. Yeah, thanks for that. Anybody else got any other questions or any observations for Karen? No.
Caroline, just to pick up on those 2 points in terms of reassurance around the framework, that is near completion in terms of the work that was undertaken. Obviously the COVID response has taken over from that at the minute in terms of the work, but Emma has been working with Gary Collier and the wider group, so that is near completion. In relation to celebrating success, absolutely, when these practices were rated as outstanding, which was a couple of years ago now, because obviously they're in a cycle, it was celebrated through the committee at that time. It was under the HAS CCG currently for one of the areas. And certainly I think one of the things that we try to encourage, and it will certainly be working with practices, is sharing best practice and making sure that they're working. And I think one of the, if you can say there's been benefits of this pandemic and the approach, it certainly has been the collaborative working that's taken place across practices now. And the joint approach to making sure that your neighbour's sustainable as well as yourself. And I think that's something that we'll be working through in the coming year as soon as we get through our COVID response, to make sure that practices are further supported. But absolutely key, Janice, I think that we absolutely do celebrate success, because there's many successes, and we do tend to concentrate on where there may have been failures or where we may need to provide support, but we should absolutely celebrate those successes. But in terms of assurance, we did at the time.
Okay, thanks for that, Karen. So if members are happy to accept the report, yeah, okay, yeah, a few nodding heads there, yeah. So the next item then is on page 59, and it's the compliance review of primary medical care commissioning. And Karen, I think you're going to take us through that.
Yeah, you're going to get sick of my voice throughout today. So in terms of the compliance review, this is a success. So as part of the 2021 internal audit plan, an audit was undertaken. It is the CCG's responsibility under delegated commissioning to ensure that we have sustainability and high quality safe care within primary care. There was an audit undertaken, and the purpose of the audit was to provide assurance to ensure that the CCG had effective arrangements in place. And the focus particularly was on finance and governance, and again the oversight of this committee. So the operational oversight of this committee in relation to ensuring that our governance was appropriate and responsive. You'll see within the report that our report has identified that we've got full assurance as a CCG that the committee has discharged its duties in accordance with the terms of reference, hence the rationale and the reason to make sure that we keep the terms of reference under regular review, that the premises cost directions were implemented and have been implemented, and that the payment system for approvals was in place. Now, there was an area identified in relation to the payment system in the approvals process through the COVID pandemic response that traditionally we would use paper and signatures in terms of signing things off, and it was identified obviously through this process that we're working in the virtual world at the moment, that we implement additional arrangements through electronic sign-off of those approvals, and that's now in place. But the auditors did provide us full assurance.
Brilliant, well done. That's excellent to see that. Has anybody else got any other questions or observations for Karen? No. Yep, David. Yep.
Yeah, just to reflect on that, actually, this is a fantastic audit report. It's really good and should give us as a committee, but also the governing body, the assurance that actually we're doing things as we should be doing. So well done to everybody involved. Really good report.
Yeah, excellent. No, that's smashing. Well done, Karen. If you can pass that on to the team as well, that would be great. So the next items on the agenda are for information. So we've got a couple of reports for information. The pharmacy application summary report and the Woodside surgery CQC report. So if we go on to page 60 first, and that's the pharmacy applications report. I've got Emma down as taking us through this, but I presume that'll be you, is it, Karen?
Yeah, so again, we regularly cite committee on the applications that are received. We're contacted as a CCG in relation to, as a stakeholder around pharmacy applications that are sent to the CCG by NHS England as an interested party. Now, pharmacy applications can be for a range of things in terms of change on location or an additional pharmacy site or additional owner or a change in ownership. So since the last update that was provided to the committee back in August last year, we have received a number of applications for comment. So there was 2 applications received for comment that we've responded to in relation to the Cooper's Chemist in Mask, and we were notified of the application for a one-off change to 4 hours, and the CCG provided confirmation to NHS England. We were also notified of a number of changes that didn't actually require comment, but they were provided to us by notification. So it was really just to cite the committee on the applications received to date, so that you kept appraised of those in the scale of wider primary care services.
Yeah, that's smashing. Anybody got any questions or observations for Karen in relation to the pharmacy report? No. No, just pleasing to see that, like you said, that gets the consideration that it gets, and it's interesting to see it through that lens. So if we can move on to the next report then, and that is the Woodside surgery CQC report. Again, this is just for information.
Yeah, so just to cite committee members, you'll be mindful of the last committee meeting that we undertook, whereby we provided under any other business advice in relation to a report that had been published but wasn't able to be presented to the committee at that time due to the timescales of the report publication and the papers required for committee. Hence, we provided an overview under any other business to make sure you were cited as members. So the reason that we've provided the CQC report in full today is so that committee members had the opportunity to read through the report and to ensure that you understood the background of the work that's been undertaken with the practice to date and the CQC findings in relation to that report. In terms of providing assurance, obviously at the last committee I did provide assurance to the committee that we have worked very closely with the practice and with CQC, with the local medical committee and also with member practices to ensure that the practice is supported, to ensure the sustainability We've supported the practice to develop an action plan, which was approved by CQC, and they are working through those immediate actions now. So really it was just to make sure that we tied up the loose ends from last time and provided committee with the full report.
No, that's smashing, Karen. Thanks very much for that. Has anybody got any questions or observations for Karen in relation to that particular report? I know we've discussed this a number of occasions, so people are okay with that. Like I say, I'm just flicking through me screen and trying not to knock you over. No, okay, that's smashing. Thank you very much for that, Karen. So the next item on the agenda is items to note and any other business. I haven't been advised of any other business, but there's an opportunity. Does anybody want to raise any other business? Can't see any hands. Oh, yep, Lisa. Hi, Lisa. Go on.
Right, sorry, I'm just trying to lower hand and unmute at the same time. Again, it's just to sort of feedback. We have got reports that are coming out of the analysis of this, but again, local communities are still feeding back that neurodiverse communities and deaf communities are having real problems accessing GPs just with having a telephone service. Quite a lot of the deaf community aren't digitally connected. I don't know what the option is. I don't know any other suggestions around this, but it's just, again, piece of intelligence I'm just bringing here to share with you, that those two communities in particular are having real problems accessing GPs at the moment.
Thanks for raising that, Lisa. Are you able to respond to that, Karen or David?
It's certainly something we need to pick up, Lisa, because obviously at the moment, with the pandemic and with the risk of COVID, practices are enacting the telephone lines to make sure that patients are clinically needing to be seen in practice. What we'll do is we will speak to NHS England, because they're responsible for the commissioning of interpreting services. And I'm sure there was a telephone service that is available, although so you don't have to necessarily go online. Obviously, if they're not digitally enabled, that's really difficult, because there is online consultation now that is available. But there is still telephone consultation. But if they're not able to access that, the only way that they would be able to access services would be through face-to-face, but a risk assessment would need to be undertaken to ensure that, one, the patient's safe, but two, the practice are safe as well. Certainly we'll look and see what's happening in other areas to see if we can determine what's best practice elsewhere as well, because it is a difficult situation at the minute for those that can't just turn up at practice like they previously would have. So we'll look into that and be able to provide you an update outside the committee, if that's okay.
That would be great, Karen. As I said, I don't know what the answer could be in terms of that, but I mean, I'm very happy to obviously see what feedback you can send us, Karen. I'm quite happy we've got quite a large network of deaf community members of the public, but also those professionals that support that community as well, and I'm very happy to maybe either facilitate a discussion to see what the actual specific issues are, or happy to take some alternatives for further discussion and feed that back, Karen. Either way, yeah, it's becoming a big issue locally.
Yeah, no bother, we'll have a look at that, because it might be there are channels available to them that they're not even aware of, in terms of e-consultation.
Can I come in, Karen? Certainly, I know they like to text, and sort of like, you know, in our practice we have like a phone to text, but I'm not sure how many people know about it. Certainly practices can do that, and there's certainly been a lot of work done in Hartlepool about poor access and practices trying to sort of like make access better. But certainly the Deaf Association sort of go on about sort of like, basically, if we're going to have a phone to text, then sort of somebody can make an appointment for them and text back. We do that with some of our foreign patients, actually, who seem to be able to get somebody to read the English and then get back to us.
Yeah, because that might be an option, but I know it depends sort of how they then prioritise the text for appointments in terms of then those that are actually making the phone calls and who gets you know, sort of added to the list for triage that day? Do they look at the phone calls first or the text, or does that mean that the texts are always getting pushed back to the queue? I don't really know how it works, but it was just something for further discussion if we can explore it. And as I say, happy to support and facilitate that, Karen.
Great, thanks.
That's smashing, Lisa. Thanks for flagging that up. I'm going to move on now, if that's okay, to the next item on the agenda, and that's questions from the members of the public. We haven't been advised of any, but Brian, have you got anything that you want to ask or any observations?
No, but it's quite fascinating, to be honest, to listen to everyone. And I must admit, to be honest, the NHS, the COVID vaccination programme has been a joy to watch the numbers grow up and go each day. You know, and to be honest, people don't realise the support network that has to be behind them numbers to get it there. But other than that, it's been lovely, been fascinating to sit and watch, been absolutely fascinating. So thank you for letting me come in. Okay.
You're very welcome. You can come every month. Thank you very much. Thank you so much. I'm pleased you've enjoyed it and found it useful.
It's been fascinating.
Brilliant. Thank
you.
you, Brian. Lovely to see you. And then the next item is consideration of any impact on the risk register. I don't think there's anything in particular that we need to flag up especially, is there? Is there anything that you've clocked, Karen?
No, nothing that isn't already on the risk register now, Caroline, thanks.
Yeah, that's what I was thinking. And then in terms of key items to report to the next governing body, obviously we'll put forward the usual report that we do to the governing body with items that we've discussed. So with that, I'll draw the meeting to a close and thank everybody for their attendance and participation. Thank you very much, and we'll see you on the 20th of April.
Thank you.
Okay, thank you. Cheerio, bye.
Thank you, Caroline.